Welcome, everyone, to the STD Clinical Case Series session. I'm Laura Coulter, and I'm a medical officer on the clinical team within the Division of STD Prevention here at CDC.
And I'm Bradley Stoner, Associate Professor of Medicine at Washington University School of Medicine and the Medical Director of the St. Louis STD HIV Prevention Training Center. Together, Dr. Coulter and I will be moderating this session today.
During this session, we will hear from 4 presenters who will be reviewing interesting, unusual, and/or complex STI clinical cases. These cases will be presented to and discussed by an expert panel of clinicians who will serve as case discussants and will review salient issues of epidemiology, clinical presentation, differential diagnoses, and management options. And at the end of the session, there will be time for both panel discussion of the cases in addition to an open Q&A with the audience.
We are greatly looking forward to an exciting session of case presentations and expert commentary and discussion.
So our first presenter today is Dr. Erin Kaufman, who is currently an infectious diseases fellow at Emory University in Atlanta, Georgia. He was previously an epidemic intelligence service officer in the viral special pathogens branch within the Division of High Consequence Pathogens and Pathology at CDC. His interests are in emerging zoonotic diseases and outbreak response and prevention. Dr. Kaufman, you can go ahead and get started.
This fantastic case series. I'll go ahead and get started here. So I'll be speaking today about an interesting case of tertiary syphilis, with some specific interesting clinical presentations as consistent with aortitis and tabes dorsalis. And I have no disclosures. So the patient was a 55-year-old man, actually previously healthy, without any known prior medical problems. And he had about 3 years of kind of very gradually, chronically smoldering symptoms, shortness of breath, bilateral lower extremity swelling, decrease in his exercise tolerance to the point that he really was only able to walk about a block or two before being winded, as well as orthopnea. And what brought him in a little bit more than those symptoms, which he was starting to get used to, was that he had noticed that in the past few months, he'd had some changes in his handwriting, and he sort of just described this as it being illegible. And then as well as some decreased sensation in his feet and kind of a slowed cognition. He just wasn't feeling as sharp as he was used to. He was previously a high-functioning tax attorney before he kind of wasn't doing so well in the last few months. And so he was admitted to the hospital the first time with some interesting new findings. So he had an elevated blood pressure and hemoglobin A1C of 11 with a new diagnosis of diabetes for him. His echocardiogram on that admission showed a reduced ejection fraction of about 40%, and he was found to be fluid overloaded with a new diagnosis of heart failure. Was diuresed with quite a bit of weight off. But his bilateral low extremity numbness never fully resolved. A fairly cursory workup was done initially, and it was suspected perhaps just due to diabetes. And he ended up being discharged to follow up with new heart failure medications and insulin for the diabetes. And so he was seen in cardiology clinic, as would be routine for this kind of a presentation, shortly thereafter, post-discharge. And despite taking his heart failure regimen appropriately, he was still feeling quite fatigued and essentially unchanged in that regard. Maybe a little bit improved, but not much from when he had presented to the hospital. And so in follow-up, more of his heart failure to kind of understand what was going on, the team got a CCTA to evaluate for underlying coronary artery disease. And that did come back with extensive 3-vessel CAD, but also finding shown here, which is something else to kind of point out. So with the yellow arrow, they're showing you just one cut of the CT, but essentially looking at that aortic arch and showing diffuse soft tissue thickening of the wall of the aortic arch. And scrolling through, as I wasn't able to provide here for the presentation, it really affected the ascending and descending segments as well, the aorta. So this, essentially was consistent with aortitis. And the astute, cardiologist that was taking care of him, I think came to a differential that would essentially look something like this, with syphilis overwhelmingly being on the differential for that, with perhaps some rare manifestations of some rheumatological diseases tucked away in there. And so the cardiology team appropriately, so syphilis until proven otherwise, the cardiology team appropriately checked an RPR that came back greater than 1 to 512 with a titer. And then the treponemial IgG returned positive. And here at Grady, we actually have the traditional screening algorithm with the treponemial IgG confirmatory test done after the RPR. And so he was at that point reviewed to infectious diseases clinic, where there was a bit more kind of review done. He identified as a man who had sex with men, had reported being monogamous with one partner for the past 5 years, was very clear about that, and had otherwise said he was entirely celibate for the prior 10 years. Had not been tested to his knowledge before for syphilis, and kind of said, well, 20 to 30 years ago, I lived in and traveled all around Asia when I was younger and more active sexually. And so he suspected maybe he got it then. An HIV test did come back negative. And so he was admitted essentially from an infectious disease clinic for concern for what was going on with the aortitis and the rest. And at that point had a little bit more of a thorough neurological exam. He was described to have a bit of an abnormal gait, and I would kind of describe it most as more just a slowing and an unsteadiness more than anything else. And sometimes it was worse than other times. What was notable in particular on his neurological exam was that he had profoundly decreased sensation. So bilaterally on the fifth digits of his on the lateral side of the fifth digits of both hands. And then on the lower extremities, more medial than lateral and more distal than proximal sensory loss. He also had a lot of sensation decrease by a pinprick in the bilateral lower extremities, again, more distally than proximally. And he also had both vibratory sensation loss, kind of up to the knees, as well as loss or decreased proprioception in the bilateral lower extremities. So an LP was obtained on admission out of concern, of course, for neurosyphilis. And you can see the results here, that a white count, but an elevated teen and normal glucose. And his CSF VDRL did come back positive, consistent with a diagnosis of neurosyphilis. He was also found to have a low vitamin B12 on the first admission, which had normalized afterwards. And so kind of putting these things together in conjunction with our colleagues in neurology, it was felt to have kind of a mixed presentation. So with some components consistent with tabes dorsalis, I think particularly some of the proprioception loss, but then also a component of diabetic neuropathy with some of the changes by pinprick and so on in the lower extremities. And then perhaps this like superimposed component of subacute combined degeneration that they could have appreciated might be due to vitamin B12 deficiency. So a bit of a mixed picture. He did have some non-proliferative diabetic retinopathy as well on ophthalmological exam. He had a fairly otherwise unrevealing brain and spine imaging, which we performed just to see if he had any evidence of meningovascular parenchymal disease, and he did not. And so he was started on treatment with IV penicillin G, received 14 days of that with 1 dose of IM penicillin G at the end to complete sort of a very latent regimen for regimen for latent syphilis. And he actually reported feeling much better fairly quickly. His handwriting improved within about a few days of starting the treatment. I didn't see it objectively, so it was per his report. And then about a week into it, he really felt improvement in his feet and some of the sensation that he wasn't that he had issues with before. So in follow-up at 3 months, really had resolution of all symptoms with some persistent ongoing lower extremity numbness and tingling that may have been more due to the diabetes, which he was being under control by, that was managed okay with pregabalin. And so I just thought I'd put out some of the leaders here. So kind of presented early on with elevator of greater than 1 to 512, received as treatment for tertiary syphilis and neurosyphilis, as I mentioned. I'm not sure why our care was checked so soon post-treatment. I think we were just trying to characterize this as we don't see tertiary syphilis quite a bit. So he'd have a decrease of greater than 4-fold to 120. One of the things that did stick to us from this case, and I'll defer a little bit more to our consultant afterwards, but was the relatively high titer in tertiary syphilis. We typically are associated a little bit more with a lower titer after it's sort of been percolating or cooking for that long, and so we were a little bit uncertain as to how consistent that was with the diagnosis of tertiary syphilis. But in the end, felt like his clinical presentation consistent. So regardless, responded appropriately to therapy, and then later on into this year, actually just moved to this year fast state there at 1 to 120. And he did present around just about a month ago when worsening chronic diarrhea. That was kind of a newer issue that he was getting worked up, and he was actually, for that reason, offered retreatment for, again, late-latent syphilis. Not really certain if he'd ever cleared or kind of what was going on. He ended up being lots of follow-up right after that discussion and moved out of state, and so I never did get. So I'd be happy to turn the floor over to Dr. Tuddenham for further discussion on this interesting case. Some of our takeaways, of course, is that tertiary syphilis is a relatively uncommon manifestation these days for syphilis, but we do still see it, and it is a severe complication of syphilitic infection. Some of the manifestations include tabes dorsalis as well as syphilitic aortitis. Certainly should always be a point of first consideration for patients that come up with an expected finding of hepatitis. That's really what led our team here to diagnose him with syphilis. And it's interesting, symptoms may persist after treatment. I think most of his resolved, and need a little mixed picture of some other diagnoses. This is another thing that we thought was of risk. Overall, 3,000-foot view is really that the incidence of syphilis, of course, is increasing in the U.S. Kind of this case, we hope emphasize the importance of routine screening for syphilis, sexually active adults, to help prevent these complications, which thankfully were not on the whole too devastating for this patient, but certainly could have been, and that certainly did cost him a fair deal of morbidity. So just wanted to acknowledge some of my other colleagues in this case, David Holland, who first saw the patient in ID clinic, and Russell Kempker, as well as Kim Morkowski, who joined in when he joined the ID, or was seen on the ID consult service, as well as Wendy Armstrong for supporting this presentation. Thank you much. I will turn it back over to Laura and Sue.
Great. Thank you, Dr. Kaufman. So our discussant for this case is Dr. Susan Tuddenham. Dr. Tuddenham completed her residency in internal medicine and her fellowship in infectious diseases at Johns Hopkins, where she is currently an assistant professor in the Division of Infectious Diseases. She is a clinical STI expert and heads an infectious diseases clinic focused on vaginitis and recurrent urinary tract infections in women. Dr. Tuddenham has recently been elected as a junior board member of the American Sexually Transmitted Diseases Association and has served as a subject matter expert for adult syphilis for the CDC STD treatment guidelines. Dr. Tuddenham, go ahead.
Well, thank you so much. And hopefully you guys can hear me okay. We had a few technical difficulties in the practice, but let me know if you can't hear me. So what a beautiful presentation by Dr. Kaufman. Thank you so much. And I think, as you pointed out, syphilis rates continue to rise. And in that setting, it's important we're aware of not just the more common presentations, but these tertiary manifestations as well. And what a fascinating example in that this involves two manifestations of tertiary syphilis, cardiovascular with the aortitis and neurologic as well. I think the case brings up a few issues I'd like to highlight. The first quick point I wanted to make is that this patient had neurologic symptoms in the setting of a positive RPR and appropriately got an LP. But just remember that it's recommended that all patients with tertiary syphilis, even if they don't have neurologic symptoms, so including those just with cardiovascular syphilis or just with syphilitic gummas, need to have a lumbar puncture due to the high prevalence of asymptomatic neurosyphilis seen in this group. So this patient, once he was found to have syphilitic aortitis, even if he had not had any neurologic signs or symptoms, would have required a CSF exam per CDC guidelines. Patients who have tertiary syphilis who do not have neurosyphilis can be treated with 3 doses of IM BPG, and they don't need IV penicillin. So first quick point, don't forget the LP in patients with tertiary syphilis, even if they don't have neurologic symptoms. Now, this patient did have tabes dorsalis. I know there's a couple other factors in there, including the B12 deficiency, but I think definitely had tabes. Most cases will occur 10 to 30 years after infection, the peak probably being around 15 to 20 years after infection. So he may have been infected with syphilis quite a long time ago, as I think was corroborated with his epidemiologic risk factors. Tabes is characterized pathologically by degeneration of the posterior roots and columns of the spinal cord, which are involved with sensation and proprioception. So patients can actually present with a variety of complaints from GI distress to swollen joints, pains, but they can certainly present with decreased sensation in the extremities like this patient. And actually, like this patient, if you go back to the old original case series, about 24% will present with paresthesia, so numbness, tingling, coldness, aching of the extremities. And like this patient on exam, about 50% will have impaired vibratory sensation, 40% impaired proprioception, and 15% impaired touch and pain. Interestingly, I think there was this talk about his changes in his handwriting. I tend to associate that more with the general paresis presentation of neurosyphilis, but I think that's interesting. Another quick point just about the CSF exam in tabes dorsalis. I think in this case, the CSF exam was really helpful. It really clinched the diagnosis with that positive VDRL. But just remember that with tabes dorsalis, as with any form of neurosyphilis, you can have a negative VDRL. Remember, when you're trying to make a diagnosis of neurosyphilis of any kind, you look for a positive VDRL, but can be negative about 50% of the time. So it's quite specific, but not that sensitive. You also look for an elevated cell count, and you look for elevated protein, although of the 3, the elevated protein is probably the least specific. We often get the question, though, can you ever have a completely normal CSF exam, meaning negative VDRL, normal cell count, and normal protein, and still have neurosyphilis? And the answer is that you can have a normal CSF exam in ocular or otic syphilis, which some might argue are not quite neurosyphilis. But tabes dorsalis is the one other example where it's reported in the literature that around 10% of cases may have a completely normal CSF. So it is possible. And that's, I think, one interesting thing to remember about tabes. Although, again, in this case, the positive VDRL was really helpful. Just 2 last points. This patient was given a dose of IM benzathine penicillin G at the end of his 2 weeks of IV penicillin. Some clinicians do this, I guess, including myself. There's not necessarily a lot of direct evidence to back it up, but it makes sense. T. pallidum is a slow dividing organism. You want to ensure that there's adequate penicillin around over a prolonged period of time, at least 3 weeks in a patient with late syphilis, as this patient had. So giving that extra dose of BPG allowed him to have good coverage for that 3 weeks. Just the very last quick point I'll make is one other issue. So as I understand it, the patient had a 4-fold decline in titer from 1 to 512 to 1 to 128. However, he didn't serovert, so he sort of stayed stuck at that high titer of 1 to 128 over a year of follow-up. And then he got retreated at a year, a little over a year, with 3 doses of BPG, maybe in part because of some questions about this diarrhea. It seemed like maybe that wasn't necessarily related. I will say that questions often arise regarding whether additional treatment is needed in patients who have a 4-fold decline but have a persistently elevated RPR titer. I think the first point to make is that it can take time for the titer to decrease, and in late syphilis, it may take up to 2 years for that patient even to achieve a 4-fold decline. So it's possible that just with some additional time and without additional treatment, the titer could go down further in this patient. But I guess a question arises what to do if you don't treat and the titer remains at 1 to 128 at 2 years. And this is not necessarily this patient, but assuming you aren't concerned for reinfection, he doesn't have any new symptoms. I think we all get a little more nervous about a titer sitting at 1 to 128 than at a lower level. But this is an area where there's not much data. I think it's worth noting that in the pre-antibiotic era, persistently elevated Wassermann test, that was the precursor to the RPR, didn't predict clinical progression or relapse in patients with late syphilis, although it did in those with early syphilis. But certainly in the antibiotic era, there isn't any good data to say that those persistently high titers will lead to worse outcomes or that giving more therapy will lead to better outcomes. So I think that many would consider giving additional BPG at 2 years if there was any concern at all for reinfection. And certainly new symptoms is a different circumstance. But then just following closely clinically, or even just following closely clinically without giving further therapy. So I think a great case, really fascinating. I'll leave it there since I know we have a lot more cases to go to.
Thank you, Dr. Tuddenham. That was fantastic. And Dr. Kaufman, really terrific case. We're getting a lot of excellent questions in the Q&A, but because we're so compressed, we're going to try to do everything at the end. We'll try to get to as many of these at the end as we can. Our next presenter is Dr. Pei-Chi Chung, who has over 10 years of experience working at the New York City Department of Health and Mental Hygiene in the Bureau of STIs. The clinical practice where she has worked specializes in the treatment of STIs and in HIV prevention, and there she has served predominantly uninsured or underinsured vulnerable minorities and LGBTQ populations with a high prevalence of HIV. Dr. Chung is going to present on acute hepatitis A and HIV pre-exposure prophylaxis, a case report. You can see your slides, Dr. Chung. We don't see you yet. Pei-Chi, can you turn your microphone on? I think we may need a little bit of tech support for this one.
We can go ahead.
Please bear with us as we sort through.
Great. So our next presenter today is Amanda Reich, who currently works with the Texas Department of State Health Services as the Congenital Syphilis Coordinator, providing guidance and technical assistance to partner services programs across the state regarding congenital syphilis reporting, facilitating and moderating fetal infant morbidity review boards on congenital syphilis in Harris, Bexar, and Dallas counties, and writing the Texas Congenital Syphilis Program operating procedures and standards. Amanda currently serves as the co-chair on the National Coalition of STD Directors Program Committee. Go ahead, Ms. Reich.
With maternal treatment. So the case began with a 28-year-old pregnant female who at 22 weeks gestation presented to a pregnancy crisis center, and her initial reason for visit was vaginal discharge and odor. She was diagnosed with trichomoniasis and tested negative for both chlamydia and gonorrhea. It was at this visit that she tested positive for syphilis and had an RPR of 1:64 and a reactive syphilis EIA. She was negative for HIV. Following her reactive lab results, the patient was contacted by regional health department staff and was also seen by a regional health department nurse at 24 weeks gestation. And a little bit about Texas is that we have both local and regional health departments. Our local health departments are primarily in our large metropolitan areas, and our regional health departments surround our metropolitan areas and often cover a large number of counties, anywhere between 10 to almost 50 counties. So a pulmonary plantar rash and a general body rash was observed by the regional health department nurse and was diagnosed with secondary syphilis ultimately. She received home-delivered bisulfite therapy, the benzathine penicillin G, by the regional health department nurse at 24 weeks gestation at that initial exam, and a secondary dose was given 1 week later. And that secondary dose was given based on the evidence that suggests an additional dose of bicillin may be beneficial for pregnant women diagnosed with early syphilis. During that visit, prenatal care and case management referrals were made to the patient. She also reported that she was taking prenatal care vitamins and that she had continued sexual contact with her partner. Her primary sexual partner was treated at that initial visit at the 24 weeks gestation. She was admitted to the hospital when she presented to a small county emergency room with the chief complaint of both abdominal pain and leaking fluid with meconium for approximately 5 hours. A sonogram was performed and the estimated gestational age was 32 weeks and 6 days. She had an elevated fetal heart rate, ruptured membranes was confirmed, and she was found to be 3 centimeters dilated. Based on the sonogram, there was concern for only a single fetal kidney. They took the obstetric history. She was found to be gravida 3, para 2. She did not enter prenatal care, unfortunately, during the pregnancy. And based on the available information, there was some weight loss during her pregnancy. And the other 2 deliveries were both C-sections. Her maternal lab results did come back while she was at the county hospital. And the temperature was normal, CBC, CMP, all labs were within normal limits. Was found to be rubella and hepatitis B immune. Her HIV lab results came back negative, and her RPR was positive. Unfortunately, they did not titer it out. The other thing was that her BP was slightly elevated. She began treatment for group B strep, which is typical for clients who do not enter prenatal care, and we don't have the results for that. She failed to progress, and because of that failure to progress, and she is at this point considered a high-risk pregnancy, she was transferred to a partnering hospital with a level 4 NICU in a large nearby metropolitan area. So some social history for our patient. She has a history of substance use with drinking beer daily, reported smoking at least a pack of cigarettes a day, and has a history of chronic methamphetamine use, reporting that her last use was 3 weeks prior to delivery. Our client was unemployed and also had a history of prior Child Protective Services involvement and did not have custody of her other children. Her eldest child was in a closed adoption, and her 3-year-old was in a placement with an extended family member. She had housing instability both prior to and during her pregnancy, as well as reporting both intimate partner violence and forced sexual activity. And she did have a history of incarceration prior to pregnancy. So she delivered following the transfer. It was a low transverse repeat cesarean, and the meconium was in fact stained. She was provided with Pitocin, magnesium sulfate, betamethasone, continued treatment for the GBS, and Cafazole at delivery. And her lab results, the CBC, CMP stayed within normal limits, both during and post L&D. And the RPR did result at this hospital, and it was 1:16, which represented a 2 dilution titer drop from diagnosis. And at this point, we're about 10 weeks out from that initial RPR of 1:64. Her syphilis IgG was positive, which is as expected, and her test results for HIV were, of course, negative because she was just tested at the county hospital. Unfortunately, the infant went into respiratory distress immediately following delivery and required CPAP. The actual gestational age that they approximated following delivery was about 1 week younger than on Sano and was 31 weeks, 5 days. APGAR scores were 7 and 7, but good news was that the infant was in the 97th percentile for both weight and length at 2110 grams and 48 centimeters. So on the congenital syphilis evaluation, an RPR was taken on the first day of life and was found to be 1 to 8. The infant was born with a blueberry muffin rash with Ripura lesions disseminated throughout the body. And also, they performed a lumbar puncture on the second day of life. The CSF VDRL was negative. However, the CSF white blood cell counts were elevated and all cells were monocytes. The CSF protein was also elevated at 225. However, the CSF red blood cell counts were within normal limits at 15. On the third day of life, a long bone radiograph was performed and symmetric lucent metaphyseal bands were seen in the bilateral, proximal, and distal humeral radius on the femurs and tibia and fibulas. So on all of the long bones, we're seeing the symmetric lucent metaphyseal bands, which are pretty typical for congenital syphilis manifestations in long bones. Fortunately, there was no periostitis. The infant also presented with thrombocytopenia, anemia, elevated liver function tests, conjugated hyperbilirubinemia, which did not present at birth, but instead appeared around the 5th day of life, ultimately worsening on the 7th day of life before resolving. And with the elevated LFTs and conjugated hyperbilirubinemia, we did also see hepatosplenomegaly. The infant also had cardiomegaly with a heart murmur, and on the 3rd day of life, ultimately was started on the treatment regimen for congenital syphilis, the 50,000 units per kilogram of aqueous penicillin G IV for 10 days. So that was good. Some other diagnostics and medical conditions for the infant was that the infant was born with a grade 1 intraventricular hemorrhage. Good news was that the infant did have both kidneys. Some bad news was that the left kidney showed mild hydronephrosis. Unfortunately, again, the infant only had 11 pairs of paired ribs instead of 12. The chest x-ray also showed mild bilateral granular haziness with lung expansion and mild surfactant deficiencies. And placenta pathology revealed changes consistent with cytomegalovirus by PCR. And so on the 3rd day of life, the infant was also started on ginsecyclovir sodium. So the cytovine was to treat the CMV. A big missed opportunity for us looking at congenital syphilis was that they didn't also test the placenta for syphilis. So there was no immunohistochemistry done and no special staining. Some additional testing results was that the hearing screen was passed, both ears, and the eye exam also was passed. So there was no evidence of chorioretinitis or any other ocular manifestations of CMV or congenital syphilis. And throughout the stay, the temperature, BP, O2 were consistently within normal limits. So it was a longer stay in the NICU, 38-day stay, and on the 38th day of life, they did do a repeat RPR, which they found to be non-reactive. That was the only follow-up RPR that was done. And the infant was ultimately discharged into CPS custody pending foster care placement with the family member, and it was the same family member that has custody of the 3-year-old child. We don't have any pictures of this case because the infant went into CPS custody. So a little bit about cytomegalovirus is that in the United States, 1 in 200 infants is born with CMV. Nearly 1 in 3 children is already infected with CMV by age 5, and about half of all adults have been infected with CMV by age 40. In our case study, there was never an urine or saliva test done for CMV, which is the preferred specimen, and our infant did not exhibit typical neonatal signs of CMV. So the infant did not have microcephaly or low birth weight, never had seizures, retinitis, or hearing issues, but did, of course, have the rash jaundice, and hepatosplenomegaly. And of course, in terms of congenital syphilis, we know it's on the rise. There were 1,306 cases in the United States in 2018. And in Texas, we had 367 cases in 2018, and we're nearly triple the national rate with 92.2 cases per 100,000 live births, making us both first in number of cases and in case rate. So this mom was adequately treated. She did receive penicillin G, which is the only known effective antimicrobial, and she did receive adequate treatment for her surveillance stage. She received 1 dose of Bicillin, which is appropriate for secondary syphilis. She even received that secondary dose that may be beneficial. And because of the blueberry muffin rash, the providers assumed, this is a torch infection. Mom has a history of syphilis. And at the time, they hadn't reached out to the health department to confirm whether or not that had been treated. And so they went ahead and went through the congenital syphilis evaluation and treatment cascade to see what do we do next. So they're assuming it's proven or highly probable congenital syphilis. But what if it wasn't, right? So does the infant have physical signs and symptoms of congenital syphilis? No. Did that infant have a 4-fold titer higher than mom's? No. In fact, this infant's titer was lower than mother's at labor and delivery. Infant's titer was 1 to 8 and mother's titer was 1 to 16. And because they did not do any testing, any confirmatory testing to truly know if this was congenital syphilis, again, this is no. Because mother did receive appropriate treatment for her surveillance stage and did not show signs of reinfection by titer monitoring, and she was treated during her current pregnancy, this is really looking like clinical scenario 3. If they're not assuming this blueberry muffin rash is a clinical manifestation, a physical manifestation of congenital syphilis. And so if they had not thought that, then they may have only treated with 1 dose of Bicillin and not done the entire workup. And in Texas, we often see the 1 dose or maybe just a recommendation for follow-up. But we were somewhat fortunate in that they did think, this is a torch infection and we're going to do everything we can to rule out congenital syphilis. And they found evidence of congenital syphilis and ultimately chose to treat the infant for 10 days. So a special thank you to Jessica Del Toro, our congenital syphilis epidemiologist, for helping me put together this slide deck. And we're going to have the discussion now. Thank you so much.
Great. Thank you, Ms. Reich. So our discussant for this case is Dr. Catherine Hsu, who is the medical director for the Division of STD Prevention and HIV/AIDS Surveillance within the Massachusetts Department of Public Health, and the director of the Rattel STD/HIV Prevention Training Center, one of 8 STD clinical training centers funded by the Centers for Disease Control and Prevention. She's also an associate professor of pediatrics and an attending physician in pediatric infectious diseases at Boston University Medical Center. Go ahead, Dr. Hsu.
Hi, everyone. Just a quick sound check. Can you hear me okay? Okay, assuming you can hear me.
Yes, loud and clear. Loud and clear.
Okay, terrific. Thanks so much, Amanda, for presenting this case, and for Drs. Coulter and Stoner for selecting this for a discussion. I think it highlights one of the greatest problems that we face in the STI prevention and control world. Repeatedly, CDC has reminded us that we have failed in our control for congenital syphilis. And at a national level and selected states around the nation, there are many, many concerns about how congenital syphilis is resurging in areas when, if you back up the bus and think about it, this is an entirely preventable problem if you just have adequate maternal treatment. I think that this brings the greatest question that probably hit everyone in the face, right, when they first saw this baby with the blueberry muffin rash. I'm sure what was on everyone's mind is, one of the questions that might come up would be, could this be congenital syphilis in spite of adequate maternal therapy? And I just want to remind people that back in the 80s, when we had a very large problem, the previous time that we had problems with congenital syphilis, many people did great work in this field, and we can build on their shoulders. One paper in particular I'd highlight would be Jeannie Sheffield's. She led a paper back in 2002, and many of you know her as the chief of OBGYN, I believe, at Hopkins at this point in time. But back in 2002, she may have been in training or just out of training, and she worked on a very important paper that led to the conclusion that congenital syphilis can occur even after maternal treatment for syphilis during pregnancy that's been verified. And the situations in which you might be most concerned for this would be if the original time of diagnosis, the mother had a higher non-treponemal assay titer, 1 to 64 or more than that. Also, there was an earlier maternal stage at the time of treatment, probably indicative, again, a proxy measure of higher treponemal burden that may potentially escape even 1 or 2 good doses of IM penicillin. A shorter interval, less than 30 days between treatment and delivery, not the case in this case, but the final feature that was identified was the case. And it's the delivery of a preterm infant, less than 36 weeks, as defined in that particular study. So there were some features in this particular case where people might have wondered if breakthrough disease might be higher likelihood. Having said that, I don't want everyone to panic about their 1 or 2 doses of bicillin that they give to pregnant women separated perfectly in time by 7 days interval to be effective and to have the right pharmacokinetic distribution. Don't panic. The rarity of the event where you still wind up having congenital syphilis even after maternal treatment, even after the risk factors that I've described, really this happens less than 10 or 5% of the time. That bicillin is effective 90+% of the time. So what might have led to this infant still having some clinical features? For example, the rash might be explained by syphilis. The LFTs could have been explained by syphilis. The bone findings, while not indicative of acute syphilitic change, could have been post-syphilitic change. What could have led to some of these findings? So the answer also lies in the fact that even when we apply appropriate therapy, the regression in symptomatology is not what we would hope for, like a snap of the fingers, right? So for example, had this mother been prenatally monitored very carefully, because she had been diagnosed with syphilis at 22 weeks, if she had had really good prenatal care and been followed sonographically, there are some excellent papers contributed again in the literature from an era when we last saw a tremendous or a higher number of congenital syphilis cases. There is a lovely paper by Reich et al. From AJOG in 2014 that pointed to some findings that tend to regress more slowly. And one of the slowest findings to regress, either on ultrasound or on physical exam, is hepatosplenomegaly, which this infant definitely had. Probably the earlier findings that tend to regress are the fluid gains, although I did have a moment of pause when Amanda was presenting this infant's initial physical exam and describing how the infant was actually a higher gestational weight than was typical for the infant's gestational age of 32 weeks. The kid probably was at the 95th centile, although what I calculated out was more like the 60th or 70th. Anyway, bottom line, this kid was not IUGR. I had a moment's pause where I wondered if the actual presentation and the weight of the infant was actually because the infant was a little fluid overloaded or had evidence of hydrops, some elements of that. And it would have been nice to see an albumin or some other features from the chemical testing that would have been done initially on the serum sample. I think it was really interesting that placental pathology and hopefully umbilical pathology was sent at all. And it is, I agree with you, Amanda, a shame that they were not able to go back. And I would actually say to you that these placental samples are so precious that in many labs they're retained for quite some period of time, and even fixed samples, this years out, well, maybe not years out, but months or weeks out, one can still go back and request testing to be done on these samples, because I think in this case, to make or break the diagnosis of was this breakthrough congenital syphilis, or was this actually associated with CMV disease, immunohistochemical staining would have been incredibly important, and a re-examination by another pathologist to look at whether this was acute velitis, acute phalangitis, or other acute features that are more associated with syphilitic changes, rather than the pathology that was associated with CMV. And what exactly was the pathology that they thought was associated with CMV? Was it inclusions? What was it that they defined, and how did they define the CMV diagnosis? Because Amanda, as you pointed out, they didn't do the gold standard tests, either in the mother or in the infant. Either titers in the mother to prove that maybe the mother was more likely to have recently acquired and therefore transmitted syphilis to her infant, or that the salivary or urinary testing on CMV, or even serum PCR, could have been done to look for CMV virus directly in the infant as evidence in support of CMV disease. At the end of the day, I think the clinicians were faced with the following problem. There is tremendous overlap in particularly between CMV and syphilis, which can both affect the skin, the eyes, the internal organs, and some features of it on clinical exam can result in the same physical appearance. And that does not help us distinguish per se, although some have higher odds of being present in CMV, some have lower odds of being present in syphilis. The fact that the infant wasn't IUGR is not a perfect marker for it not being CMV, or the fact that the infant was not deaf at birth is not a perfect marker, as many of these findings that are indicative of congenital CMV are findings that happen later or present later. The bottom line is there's too much clinical overlap. I am delighted to hear that they bit the bullet and elected to treat for both, although it does give me a little pause, because anytime we treat with ganciclovir or valganciclovir in a little boy, and I wasn't sure what the gender of the infant was, we worry about the long-term consequences, although we just go ahead and bite the bullet and treat for CMV if we truly believe CMV is there on pathology, which I would have wanted re-reviewed before such an act was taken. I'm glad they thought of both. I'm hopeful they thought of even more diagnoses than we had time to discuss today, and I think I'll leave it there.
Hi there, this is Dr. Chung. Sorry for the technical difficulties, but thank you for joining me. Today I'll be sharing a case report of a patient with acute hepatitis A who is seeking HIV pre-exposure prophylaxis, or PrEP, in one of our New York City Department of Health sexual health clinics. Typically, the New York City Department of Health receives 0 to 3 reported cases of non-travel related hepatitis A in men who have sex with men. However, in March of 2017, the New York City Department of Health began identifying an increase of hepatitis A cases among MSM, and by the end of the year, 77 cases were found in this population. Among MSM, hepatitis A can be spread through direct oral anal contact or contact with objects that have been contaminated with the stool of an infected person. Hepatitis A is a vaccine-preventable illness, and the ACIP recommends that all MSM receive 2 doses of hepatitis A vaccine. To provide herd immunity among MSM, a critical threshold of 70% hepatitis A immunity is needed. A recent study of 4,233 MSM initiating PrEP and post-exposure prophylaxis, or PEP, in our New York City sexual health clinics showed 65% had immunity to hepatitis A. Of the 58% who self-reported having the vaccination, only 37% were actually immune. The national guidelines for MSM seeking PrEP, which do recommend testing for hepatitis B and C, do not, however, recommend routine hepatitis A testing. At the New York City Department of Health sexual health clinics, we test all patients starting PrEP. So the case I'm going to discuss today is of a 28-year-old HIV negative MSM who came to the sexual health center because a partner of his told him to get tested. He didn't know if he was exposed to an STI, but he complained that I feel tired all the time, my eyes are a little yellow, and my stomach is hurting a bit. He also complained of nausea and vomiting for 1 week. But he denied any fever or diarrhea. He had no STI symptoms, and at his previous visit 3 months ago, he had started treatment for late latent syphilis, but missed the 3rd bicillin dose. This patient did not have a history of taking PEP or PrEP. The last sexual contact was 1 week prior to his visit, and he reported only 1 male partner in the last 3 months. He engaged in both oral and anal insertive and receptive sex. His past medical history was only of anxiety, and he had no history of liver disease. For immunizations, he reported having hepatitis A and B vaccinations. Clonazepam was his only medication, he had no allergies, and he reported using ecstasy and GHB. So on physical exam, it was actually difficult to assess this patient for jaundice because he had applied an artificial self-tanner all over his skin, but he did have significant bilateral icteric sclera. He did have a mild epigastric tenderness, but no hepatomegaly or right upper quadrant tenderness. The rest of his physical exam was unremarkable. At this visit, he only had STI testing. His gonorrhea and chlamydia NATs tests were negative in 3 sites: the oral pharynx, urethra, and anorectal sites. His 3rd generation rapid HIV test, as well as his peanut HIV tests, were both non-reactive, and his RPR was 1 to 4, which had declined from 1 to 32 in June of 2017. Since acute hepatitis is beyond the scope of our practice within the sexual health clinic, the patient was referred to the nearest emergency room for evaluation. We did retreat him for the late latent syphilis, and because he was very busy with his schedule and could not return for the 3 weekly bicillin shots, we switched him over to doxycycline for 4 weeks. On day 4, the patient returned, complaining that the doxycycline was causing GI upset and diarrhea, and he wanted to switch back to bicillin for the late latent syphilis treatment. He had not been sexually active since his last visit and reported feeling less nauseous. He also explained that he did go to the ER immediately after the first visit and was diagnosed with an unspecified viral hepatitis without hepatocoma, and he was discharged on ondansetron. The labs from the ER showed markedly elevated liver function tests and transaminases. So you can see the AST was 1186, ALT 4302, ALK-Phos 327, and total bili 6.9. Incidentally, these were the highest AST/ALT levels among our PET, PrEP, and HIV positive patients in our sexual health clinics for the past 5 years. On this visit, we repeated his hepatitis and metabolic panel, and we restarted him on Bicillin for the syphilis treatment. The patient navigator set up a follow-up appointment for evaluation of the hepatitis, and the patient was counseled to avoid hepatotoxic substances like alcohol, acetaminophen. The patient expressed interest in starting PrEP at this visit, but we deferred it until the acute hepatitis had resolved. The patient navigator also set up an appointment at a partner clinic for the PrEP initiation to occur at a later date. The results of this lab work confirmed an acute hepatitis A infection with both reactive IgG and IgM. He was immune to hepatitis B, and there was no hepatitis C found. The LFTs were still elevated, although the AST and ALT had started to decline. On day 11, the patient returned for a third visit for his second Bicillin shot, and he reported that the nausea and epigastric pain had fully resolved. On physical exam, there was no evidence of scleroicterus, abdominal tenderness, or hepatomegaly, and the liver function tests were improving, but still elevated, as you can see in this fourth column. On day 19, he returned for his last Bicillin shot. He reported that he had seen the hepatologist for follow-up and had another follow-up appointment in 2 weeks. He remained asymptomatic, and the LFTs continued to improve but had not yet normalized. So PrEP was still withheld at this visit. So this case illustrates the importance of having a high index of suspicion for hepatitis A and MSM presenting with jaundice and GI symptoms, even if they report a history of vaccination. Emtricitabine tenofovir, which is used for PrEP, is known to cause GI discomfort, so it's best to defer PrEP initiation until the acute hepatitis A symptoms have resolved, so that the patient is more likely to tolerate and adhere to the medications. This patient was not able to even tolerate the GI upset caused by the doxycycline that he was on. Delaying PrEP initiation can also reduce the chance of further hepatic injury, since nucleoside analogs have been reported to cause lactic acidosis and severe hepatomegaly with steatosis. Although the national guidelines don't recommend hepatitis A testing in MSM initiating PrEP, this case illustrates the importance of checking a hepatitis A serology and vaccinating MSM seeking PrEP. So I wanted to thank Drs. Tarek Makati, Julia Schillinger, Preeti Patella, and Susan Blank, and our entire staff at the New York City Sexual Health Clinics. Thank you.
That was superb, Dr. Chung. Thank you very much. Our discussant for this case is Dr. Christine Johnston, who is an associate professor in the Division of Allergy and Infectious Diseases at the University of Washington. He is a clinician scientist who conducts research focused on genital herpes simplex virus infections, and she is also the medical director for the University of Washington STD Prevention Training Center, part of the CDC-funded national network of STD clinical prevention training centers.
Great, thank you. Dr. Chung, that was a fantastic presentation and case, really illustrating the emerging infection of hepatitis A, which is kind of reemerging as an STI among MSM. So a couple of questions I have for you actually before getting started. I was just wondering if there was any history of travel for this patient or his partners, and if we know anything about his sexual practices, particularly fecal-oral contact.
This patient did not report any recent travel, and in terms of actually occupation, that was another thing to think about. He was a hairdresser, so I don't think that it was any related to the hepatitis A acquisition. In terms of his sexual practices, he did report both receptive and insertive anal intercourse, as well as oral, receiving and performing oral sex on male partners.
Great, thank you. And of course, I'm asking those questions because there is a large outbreak of hepatitis A in MSN in Europe. And so there are some travel-related cases there. And then as well, the fecal-oral contact would be the main presumed route of transmission. So I wanted to talk quickly about hepatitis as an STI or STIs that present as hepatitis. Of course, we think about hepatitis A and hepatitis C, particularly with that elevated transaminase level. I think in this case, it was a pretty a great workup and a slam dunk diagnosis because you had the Hep A, IgM, and IgG. But just a reminder that for hepatitis C, antibody does not rule out acute hepatitis C. If that hepatitis A, IgM, and IgG were negative, I would definitely be looking towards a hepatitis C RNA to rule out acute hepatitis C. As well, primary acquisition of CMV and HSV can cause hepatitis. CMV would usually cause more of a hepatitis with mild transaminitis and a mono-like syndrome, and HSV can cause fulminant hepatitis, usually in pregnant women is where it's classically described. So not really fitting this presentation. And then finally, we always think of syphilis, which can cause more of a granulomatous hepatitis with elevations in ALK Phos and Billy rather than the elevated transaminases, and usually occurs in secondary syphilis. In terms of the clinical case and the progression in this patient, I think he had a pretty classic resolution, really with symptoms resolving over 1 to 2 weeks, and then the LFT abnormalities lagging behind. It is important to realize, however, that people can become quite ill with hepatitis, with acute hepatitis A. And in New York, in the series of MSM that was published in MMWR, described in that 2017 outbreak, 33% of people with acute Hep A were hospitalized. So people can become quite ill. This again really demonstrates the changing epidemiology of hepatitis A. So as Dr. Chung mentioned, there was a large spike in 2017. And there was actually a series of 46 cases described among MSM within New York City, with a total of 51 cases linked around the country. And this was part of an outbreak investigation, and these were all a genotype 1A strain, which is the strain that is circulating in Europe. So definitely seeing some local spread now of that strain. In addition, I think, of course, we are all here because we want to prevent STIs, and this really highlights the need for hepatitis A vaccination. We really do have a great preventive strategy here. Hepatitis A vaccination has been recommended by CDC since 1996 for MSM. But as Dr. Chung showed, the rates of vaccination are suboptimal among MSM. I think nationwide, the rates are more in the range of 25 to 45%. So really a missed opportunity. I think especially as Dr. Chung highlighted in the context of starting PrEP, it should be something that's really considered and made part of the strategy when starting PrEP, that is always checked. In addition, I think for those living with HIV, there's a new recommendation by ACIP that all people living with HIV should be vaccinated for hepatitis A with a post-vaccination serology. So that's a new recommendation that's out there. And then, as Dr. Chung highlighted, many people who had a self-reported history of hepatitis A vaccination are in fact not immune. And so that's always important to consider whether they did not actually become vaccinated or perhaps didn't have adequate response. And then finally, I wanted to raise that there have been some cases of acute hepatitis A anecdotally among people who have hepatitis A, who had prior evidence of hepatitis A immunity. And in the New York City series, there were 3 such cases, and I have heard of anecdotes as well in Seattle. And we've seen some cases here of people with Hep A who are living with HIV and had a prior documented immunity. So no changes right now to how we're vaccinating, but that's just something to be aware of, and I think a really interesting area to watch for the future. My final just quick thought is, this patient was presenting for a PrEP, and I think that is a really difficult balancing act. Again, I think as highlighted by Dr. Chung, when do you start PrEP in this case? You definitely don't want to confuse the GI symptoms and the startup syndrome, but as well, the patient is at risk. So kind of starting as quickly as you can while still being safe. And I'll end my comments there. Thank you so much.
Thank you so much.
Thank you, Dr. Johnston and Dr. Chung. It was a great case presentation and a great discussion. Our final case today is going to be presented by Dr. Waji Asghar. Dr. Asghar earned his medical degree from the University of Kalamun in Syria in 2015. He then completed his internal medicine residency at Aurora Healthcare in Milwaukee, Wisconsin between 2017 and 2020. Currently, Dr. Asghar is an infectious disease fellow at the University of Cincinnati. He has interests in public health, HIV, and transplant infectious disease. Dr. Asghar, welcome.
Hello all, can you hear me?
Yes.
Okay, thank you for the introduction. I'm so delighted to be here today to present this interesting case. And I'm just gonna jump to my presentation for the interest of time. I'm presenting a case of an African-American female in her 60s who presents to her a primary care doctor with the chief complaint, I need a cane. Patient states that she has been experiencing progressive balance impairment, worsening weakness, and shooting pain in her legs and thighs for the last few months. Review of system, basically unremarkable. Patient denies fever, chills, rash, bladder or bowel issues, and she does not have any current concerns for STDs. For family members, they are saying that the patient has been experiencing and having some cognitive impairment and memory loss for the last few months, and that she has been falling at home, and they said that she has been walking funny, but there has been no witnessed head injury. Past medical history is remarkable for hypertension, chronic kidney disease stage 2, and hearing loss in the setting of neonatal meningitis. Her medications is only some antihypertensive medication and over-the-counter vitamins. Socially, patient is a former smoker. She denies any drugs, and she drinks alcohol socially. She is not sexually active as her husband died many years ago. She denies any multiple sexual partners in her life. She does not remember that she has been diagnosed with STDs in her lifetime, and she is a retired cook. And she said that she had to quit her job about 2 to 3 years ago because of the ongoing shooting pain in her lower extremities. We did some chart review, which is showing us that the patient was actually evaluated by a neurologist for balance problems about 10 months prior. Thorough workup at that time was unremarkable, except for positive RPR with titers of 8, and multiple attempts to contact the patient at that time were all unsuccessful, including phone calls and a letter that was sent to her house. Physical examination today in the office, vitals are unremarkable. She doesn't have rash, there is no heart murmurs, and she's afebrile. Neurologically, cranial nerves are basically intact except for bilateral hearing impairment, no Argyll, Robertson pupils. There is an appreciated cognitive impairment with MMSE and MoCA 19 out of 30. She does have wide-based gait. And regarding Romberg, she was unable to maintain her balance when feet are together even when her eyes were open. And there was decreased sensation of vibration and proprioception and position below the knees, and coordination is abnormal. Here we contacted the Department of Health to gather more information about the patient. And it looks like the patient was diagnosed with secondary syphilis in 1980 with RPR of 64. Patient had a repeat RPR for some reason in 1986 with titers of 2. And after that, we don't have any documentation or proof of appropriate follow-up and treatment. Here we advise the patient that we need to admit her to the hospital for further workup and assessment. And after we did some STD workup, which came back positive for 2 treponema tests, including TPPA and EIA being both positive. Her RPR at that time was 4. And after an unremarkable CT of her head, we did lumbar puncture with CSF showing that she has elevated protein at 76, no pleocytosis, and negative VDRL and FTA-ABS. With this complex picture, we wanted to rule out any other causes. So we performed brain MRI, MRA, which came back showing that patient has fusiform aneurysmal dilatation of the distal M1 segment of the left MCA. Given the patient history, radiologists reported this as a lytic aneurysm, as we all can see here in these 2 images. We consulted neurointerventional team at the hospital, and they recommended doing intravessel wall imaging, which is a novel technique that looks and evaluates the vessel wall and gives us information if there is an ongoing inflammation. And this is an interesting finding where we found that the previously reported aneurysm has a thin circumferential hyperenhancement, which is likely suggestive of an infectious versus inflammatory process. And given the patient history, again, radiologists reported this as lytic aneurysm, as we all can see here with the yellow arrow. Now I have a question to the audience. You should be able to see the poll question just popped up. We just would like to see how you would approach a case like this. And what is your thought about this case and how we should proceed? Okay, I'm seeing some answers coming along. Okay. Here we discussed with the ID service at the hospital about what we should do now. We have an interesting presentation, suggestive clinical, physical examination, RPR of 4, elevated CSF protein, a novel technique showing us that the patient has an aneurysm with an inflammation. But we have this, on the other hand, we have negative VDRL and FTA-ABS and CSF. We discussed with the patient and we proceeded with treating the patient for neurosyphilis for 14 days. Physical therapy initially recommended that patient needs to go to the rehab because of her weakness and imbalance issues. But eventually, a few days after the ongoing treatment, patient got better, and she was actually discharged home with home therapy after she finished her 2 weeks of penicillin. Patient was seen in the clinic 2 weeks after the hospital discharge, and she reports subjective improvement in balance, gait, and that the shooting pain in her lower extremities that had been ongoing for a long time has essentially resolved. She reports no falls at home since her hospital discharge. Get up and go test in the clinic reveals significant improvement in her balance. Romberg test is negative even when her eyes were closed. We repeated the intravessel wall imaging 5 months after the treatment. And as we all can see here, that the aneurysm is still there. However, the previously reported circumferential hyperenhancement surrounding that aneurysm has essentially resolved. And this is compatible with resolution of previous active inflammation. As we all can see here, on the left side of the slide, we have the pre-treatment imaging showing that thin layer of hyperenhancement, probably suggestive of inflammation. On the right side, we have the imaging that is not showing any surrounding inflammation of the same reported aneurysm. Just a quick follow-up on the patient 1 year after the treatment. Patient is still reporting no falls at home, and we were not able to assess her in the clinic because of the ongoing pandemic. She was afraid of coming to the clinic. We were able to get RPR on her, which is showing that 12 months after the treatment, she's still hovering between 4 and 8. This has not changed much. Now, the point that I would like to raise here is that, first of all, we have this intravessel wall imaging showing us an aneurysm with surrounding inflammation pre and post treatment for neurosyphilis. This has not been reported in the literature yet with this type of novel technique. Given the patient history, physical examination, positive RPR, this finding, but negative VDRL and FTA-ABS and CSF. But she did have subjective improvement with 2 weeks of and objective improvement with treatment for neurosyphilis. So my point is, could we implement or utilize novel techniques in the management of challenging or similar cases of neurosyphilis in specific and STD in general? I would like to thank all of you for being here today. I would like to acknowledge the team that assisted us in taking care of the patient, Dr. Nadeem, Dr. Hunter, Dr. Stoner, Dr. Dolby, and Dr. Wolf. This is my contact information. Thank you all.
Thank you, Dr. Oscar. What an interesting case. To discuss the case, we have Dr. Ina Park, who is an associate professor in the Department of Family and Community Medicine at UCSF. She's also medical director of the California Prevention Training Center and a consultant in the Division of STD Prevention at CDC. She is co-author of the upcoming 2020 STI treatment guidelines and the author of Strange Bedfellows, Adventures in the Science, History, and Surprising Secrets of STDs, which will be released in February 2021. Dr. Park.
Brad, can you hear me?
Yes.
Okay, great. Thank you, Dr. Oscar, so much. I really appreciate the opportunity to comment on this very unusual presentation of what is presumed to be meningivascular syphilis. And certainly, vascular syphilis has been described and is a process really involving inflammation or arteritis. And that can happen both in large and small vessels, such as the medium and small intracranial vessels, but rarely does it involve aneurysmal dilation, as was seen in this case. One thing that we talked about earlier in this case series was inflammation of large vessels such as the aorta and aortitis, which can happen both in early and in late syphilis, but aneurysms we would expect to see, later in disease. But again, when we talk about aneurysmal dilation, they typically involve large vessels, and the thoracic aorta being the most common. But less commonly, there have been case reports of the abdominal aorta, and I decided to do a quick review of the literature to look at aneurysms for other arteries related to syphilis, and I found less than 25 case reports ranging from subclavian and pulmonary arteries to the hypogastric and SMA, and then even in the extremities, including the popliteal arteries. But I found only one other case report looking at intracranial aneurysm, which was presumed to be syphilitic in origin. So I want to let the audience know we're seeing not just a zebra, but a golden unicorn here, a rare manifestation of a rare complication of syphilis, which in and of itself is not a very common infection compared to other STIs. And so I want to talk about the patient's presenting symptoms in lab work for a second, because Dr. Oscar mentioned that the patient was having memory loss as well as falls due to loss of balance, and she had a positive Romberg, which would point us to a deficiency in proprioception. And so the aneurysm, depending on the size and location, could certainly cause some of these symptoms, and can also, depending on the location, lead to other neurologic deficits. So folks could present with visual changes, dysarthria, in addition to the symptoms described by Dr. Oscar earlier. If you guys can recall that this patient had a RPR of 1:64 in 1980, and by 1986, her titer had declined to 1:2. And remember, she also denied a history of syphilis, and there appeared also to not have been any treatment in this case. So, what we saw earlier in the first case in terms of declines in titers and the sort of pace of decline, Arlene Senya looked at this, and typically, the vast majority of folks, in fact, almost 90% of folks, will get a fourfold decline in about 3 months post-treatment. And this is what we saw as well in case one. And in this case, we saw a 16-fold decline, or sorry, a 32-fold decline in the period of 6 years. And so this certainly could happen in a patient with untreated syphilis. And the point I wanted to make to folks listening is that titers will decline, non-treponema titers will decline without treatment. It's just that the rate of decline is slower. And in fact, in patients with late syphilis who have not been treated, you can still have a completely negative non-treponemal test. And and someone's commenting they can't see my presentation. I don't have any slides. We're just talking. So if we go back to the CSF results on this patient, Christine O'Mara, who I saw was in the chat, who I'm grateful is here, published some typical CSF profiles for folks with neurosyphilis, including those who are having sort of more acute meningovascular inflammation. And we would have expected in a more acute process to see more inflammation. So whites of 10 to 100, protein of greater than 100. And in this particular case, the protein was elevated, it was only 76, but she did not have pleocytosis. And I think another take-home point with neurosyphilis is that in later neurosyphilis, certainly the CSF can be just mildly abnormal or entirely normal. And again, I don't know how it would have looked earlier in her disease process. And I think Dr. Oscar mentioned that both the CSF VDRL as well as the CSF FTA ABS were both negative in this case. As Dr. Tuddenham mentioned earlier, the CSF VDRL is not sensitive. I mean, it's very helpful if it's there, but we can't really use it to rule out neurosyphilis. And even though the CSF FTA ABS is a more sensitive test, and it was negative in this case, I think obviously the right thing was done here in terms of presuming that this was neurologic, involvement with syphilis and treating for that. And so I want to take a moment to discuss the imaging modality for a moment. Dr. Oscar was kind enough to provide me with a review article on intracranial vessel wall imaging, which I was not familiar with. And I read it as I was trying to fall asleep, and it was helpful. It was very soothing, very complicated technique. But to summarize for folks, it's a newer type of MRI, which not only allows for characterization, of typical structures, but it really emphasizes the vessel walls and not just the lumen of vessels. And so this patient had an MCA aneurysm, and the presence of a garden variety aneurysm can certainly be diagnosed with a traditional angio, CT angio, or an MR angio. But what this intracranial vessel wall MRI added here was that dimension of looking at vessel wall enhancement, which then provides more evidence that this is an inflammatory process or an infectious process. And I think in this case, maybe Waji, you would agree, like it really helped solidify the diagnosis, given that we saw clear inflammation in the vessel walls in this point. And, had she only received a traditional MRA, someone could develop and had not had this known syphilis history, it could easily have been missed, this diagnosis. Finally, in the last moment, I just don't want to skip over the fact that this patient happened to be an African-American woman who apparently wasn't treated for secondary syphilis in the 80s. And she was diagnosed, with an RPR of 1 to 8, many, many years later, and was lost to follow-up again for several months until she actually presented with gait issues. So it makes me wonder about either personal or other structural factors that played a role in the lack of access to care. Was there medical mistrust going on? Was there a lack of insurance going on, or other circumstances, that led to the barriers? And so I think this case is complicated because, it's not definitely, it's not a definitive sort of case, but because there are other neurologic, factors involved as well. But the fact that there was some improvement with treatment, makes me feel as if, the right thing was done here. And I think the only question that I would have was there any consideration to adding another dose of benzathine to complete a 3-week therapy, which would be similar to what would be done in, late syphilis, because I assume she received 2 weeks of IV penicillin. But those are my thoughts.
Yeah, thank you so much for this discussion. It's really a great discussion. We thought about giving her another dose of penicillin before she goes home, but she was having significant improvement in her gait already. She had Romberg negative. She was just running the hallways without a cane or any assisted device.
That's great.
So we thought that whatever was there was just taking care of 2 weeks of penicillin.
And I'm going to steal from Khalil's comment in the chat box that, he was thinking that it's possible that she had some element of tabes dorsalis here as well, in addition to the other factors going on. So thank you, Khalil.
Thank you.
That was excellent. We're so close on time, and it was what a great session. I wanted to, we were going to invite all of the presenters and the discussants to turn your camera and microphone on, but we have to end right at 2:30 for the debate. So perhaps time for just one more question, or for one question. Dr. Hansfield had raised some interesting questions about fluidic presentations, and particularly in case 1, Sue or Erin, if you're still on, could this have been early syphilis? The patient presenting with aortitis, could that be an early presentation? Because other imaging modalities, we're seeing now intracranial MRI, but also PET scan is showing the possibility of early vascular involvement in syphilis. So is that a possibility?
Do you want me to take that?
I know we're having some issues with the.
Sure. Do you want me to take that?
Online,
I don't see Erin. Can you hear me okay?
Yes, I can hear you. I'm not turning on my video in case that's the issue, but please, your thoughts, Sue, would be great.
Oh, well, Erin, you should go ahead first if you'd like. But
we have just 1 minute. We have to stop.
Okay, so I think that's a really interesting point. And there were some sort of atypical features here. I think the point that aortitis may be seen in early syphilis is an important one. I believe there was a case series published maybe a couple years ago by Jeff Klausner, where interestingly they did PET scans on patients with early syphilis and showed that many of them actually had evidence of aortitis. So I think it might be there more often than we even know in early syphilis. And I think that's a good point that could occur in earlier stages, not always just as a tertiary manifestation, although that's what we're classically taught. I mean, I think his tabes dorsalis, that was fairly classic. So that sort of makes me think, combined with his epidemiologic risk factors, at least if he's telling the truth, that this infection was acquired quite a lot longer ago. But I think that's a great and really important point.
Well, Dr. Quilter, are you on? Because we want to close up and we want to thank all of the presenters and the discussants for these excellent cases. It's really heartening to see the quality of the work that our colleagues are doing in the field. So thanks, everyone. Laura, if you're there, we're going to turn into a pumpkin right now.